Yeah. There were like 6
They've been chatting. They're all supportive while we get this together.
Hi, everybody.
There we go.
Okay, so we're gonna go. Is everybody on? Everybody who's supposed to be on?
I believe so, yes. Do you want to do a roll call?
Aquila, can you guys do a roll call? I've got my little hands full.
Yes. Satu?
Here.
Tora?
Here.
Kiki? Samsara?
Here.
Sumi?
Here.
Miss Jennifer?
Here.
We got Miss Lisa Davis?
Here.
Jaisha?
I'm here.
And I did say Jennifer Phillip, right? Jennifer?
Yes, I'm here.
Okay. Aquila's here. Debbie's here. I believe we're all here.
Okay, so it's time to go live, I guess.
Okay. So, yeah, I don't have that option of doing it, Debbie, but I can walk you through it.
I should be able to do it. I don't know what.
Yeah.
Oh, I think it went live automatically. That's why everybody's hearing us. Greetings, everyone.
Hello.
You guys write in the chat box if you guys could hear me.
Yes.
Yeah.
Yes, right on. Okay. So my name is Debbie Hailu, and I'm a program coordinator for Healthy Black Families. And we have decided to put this webinar together for Black Maternal Health Week. And let's see, as you can see here, and it was brought on by Black Mama Matters, and our executive director, Rahwan Naguse, said, hey, what about we do the Alameda County slant? So we brought together a bunch of beautiful birth justice workers and activists, community lovers, to talk about Black families navigating birth during COVID-19. Just an overview here. A little housekeeping. All of you, please put yourselves on mute. Question and answer is enabled, so anytime questions come up during this, please feel free to put it in the questions. And those of you who are looking at the questions, if you see a question you really want answers, put a thumbs up by it and it will put it up in the queue. And we'll do, so everybody's cell phones off, panelists. Introductions. I already said who I am. Dr. Vicki Alexander is our board president and founder. Rahwan Naguse is our executive director, and Mama Ayana is our program director. Then we'll talk a little bit about pregnancy, birth, and postpartum, both in the hospital settings. We have RNs who are active, and Jaisha is a midwife who works in the hospital scene. Lisa Davis is a midwife who works as an RN when she's in the hospitals. And then we're gonna talk about pregnancy, birth, and postpartum as home births during these current times. Then we'll talk a little bit about doulas and midwives and the new climate we're finding they find themselves in, and the opportunities that COVID-19 is presenting. And then we'll do question and answers at that point. We'll go through the questions and we'll have the panelists answer them. And then for closing, I have a question I'll ask the panelists, one question, and everyone goes around and answers. And then there'll be a quick survey that Aquila will put up when it ends for you to tell us how it went. So with that, introductions. We have Lisa Davis. Lisa says, greetings, my name is Lisa Davis. I'm a certified nurse midwife who practices home birth with the wisdom of traditional midwifery. I'm a mother of 2 daughters, the grandmother of 2 grandsons, and an activist. I believe that birth is sacred, and I believe in the body's ability to birth. I serve all people, but specialize in African-centered care using the midwifery model of care and the wisdom of Black midwives. I have over 20 years of experience working with birthing people as a labor and delivery RN. I have seen the wisdom of traditional midwifery improve outcomes and experiences. Also a co-founder of Justice Coalition for Vallejo, which is sister organization of Anti-Police Terror Project and Justice Teams Network. Woo, woo. An organization that confronts police terror through supporting families of police violence and organizing a change and create policies such as to hold police more accountable for murdering Black, brown, and indigenous folks. Next, we have Sumaya Franklin. Sumaya says, I think that as oppressed and marginalized people, the most revolutionary thing we can do is heal. Sumaya Franken is a full spectrum doula, a traditional midwife, CPM candidate, an advocate, a facilitator, and an artist. She's deeply humbled by the power of birth and aspires to primarily serve those least likely to have access to her services. She's been studying pregnancy, birth, and postpartum periods since high school. She jokingly says that she first advanced as a doula when she was 3 years old. And I don't doubt that. When her aunt gave birth to her first baby cousin. However, she has been a professional doula for well over a decade. Her background as an artist, organizer, and an educator greatly informs her practice and extends out into her work as a facilitator. In 5 years, she hopes to be practicing as a midwife, a mother, and traveling around the world. Also to have figured out her role in closing the gap in health disparities that plague the Black, people of color, poor, queer, incarcerated, disabled, and trans communities. She's a visionary. Determination fuels her as she treks on her path. Next, we have Asatu. Asatu is a midwife, dancer, mother, health educator, comedic yoga practitioner, organization leader, and healer. She began studying holistic health and natural medicine as it relates to people of African descent in 1990. Her interest in traditional and preventative health led her to midwifery, the original community health workers. She began her midwifery education in 1995 with Elizabeth Davis, the director of Hearts and Hands Midwifery Intensives, and the National Institute of Midwifery after studying biological science and liberal studies. She later trained as a doula in 1996 and began attending hospital births as a volunteer doula and resource mother for single mothers through Stanford Hospital's Black Perinatal Outreach Program in East Palo Alto, providing pregnancy support and labor assistance. Next, we have Kiki Jordan. Kiki is a Bay Area native. She is trained in home and birth center settings. She's passionate about creating ways for midwifery care to be accessible to women of color, specifically Black. Kiki is the former director of Marin Family Birth Center, a federally qualified health center that prioritizes services for families with Medi-Cal. She's a mother of 1 son, a home birther. Samsara Morgan. Samsara Morgan is the mother of 5 sons and the grandmother of 3. She has been a doula for over 40 years and has served over 1,000 births. She's the executive director and founder of Nia Healing Center for Birth and Family Life, Oakland Better Birth Foundation, and Shipra Circle Community Doula Program. She has trained Bay Area doulas for over 20 years for her own organization. Since 2016, she has been honored to be a trainer for SMC Full Circle Doula Birth Companion Training Program, formerly ICTC, International Center for Traditional Childbearing. She has written She has written for several publications and is the author of The Birth Plan. Her new book, Birth a Black Woman's Guide to Surviving and Thriving, is expected in spring 2020. Samsara serves on the board of Pacific Family Fund, which supports reproductive choice for families wishing to birth in the Bay Area's Pacific Maternity Center. Samsara is an apprentice midwife studying under midwives Laura Perez and Judy Luce. She's a student of the National Student of Midwifery. Next, we have Jennifer Phillip. Jennifer Phillip is an RN. She became a nurse in 2001, has been a labor and delivery nurse since 2005. She's born and raised in Brooklyn, New York, later settled in the Bay Area in 2014, providing hospital care for expecting families. Next, we have Tora Stigner. Tora works as a labor and delivery nurse in Berkeley, California, where she has been residing for the past 21 years. She specializes in supporting patients who want less intervention and or medicated deliveries. She has been a labor doula for her private clients for 24 years. She's an adjunct professor in an A&D program, teaching maternity nursing skills. She has been serving the Berkeley Health Commission for 2 years and is a member of Mother to Mother's program. Postpartum, a reproductive justice and postpartum meal share program. Next, we have Jaisha Wren. Jaisha completed her midwifery education at University of California, UCSF, class of 2015. She now works as a full-scope midwife for Alameda County Health Systems, Alameda County Safety Net Healthcare provider. She provides labor and delivery care at AHS's Highland Hospital in Oakland, California, and prenatal and postpartum care at AHS clinics in East Oakland and Newark, California. Jaisha is passionate about providing midwifery care, that loves people up, honors their dignity and autonomy, and respects their body's natural process. She's co-founder and program coordinator for Beloved Birth Black Centering, which is a very exciting program. Group perinatal care by, for, and with Black people. This program is a collaboration between AHS and the Alameda County Public Health Department and will provide holistic, culturally attuned, and racially concordant perinatal care rooted in the frameworks of health equity, Black feminism, reproductive justice, and research justice. Additionally, she's co-developer of Alameda County Health Developers Embrace Her Childbirth Education by, for, and with Black people. After becoming a midwife, Jaisha has provided workshops to clinics on the use of structural competency to address racism, and co-authored a paper and textbook chapters on racism related to midwifery and GYN care in the Journal of Midwifery and Women's Health, Varney's Midwifery 6th edition, on and on and on. She is committed to helping to restore the racial diversity of midwifery, creating a profession that reflects the racial demographics of the communities being served. She stays engaged in UCSF's midwifery program as volunteer clinical faculty, focusing on efforts to increase the racial diversity of midwifery cohorts. Jaisha is a mom of one son, Nadav. Did I pronounce that right?
Yes, you did.
Yay. In addition to him, her loves include Afro-Latin dance, capoeira, movies, arts and crafts, and big trees. Next, we have Aquila Shaheed. Focusing her efforts on improving the birthing outcomes of women, especially women of the African diaspora, she began a private practice through Supreme Mother Earth, utilizing ancient healing methods such as vaginal steaming, essential oils, crystal therapy, Reiki, and a plethora of other healing modalities. She empowers women to empower themselves and others. Aquila believes it is vital to encompass our health holistically by understanding the importance of birth imprints and how that affects generations to come. That's deep. For the past 8 years, Aquila has been assisting families navigating through the medical care system and create their own space for home births. She continues to be an active voice in the community by providing platforms for youth to speak, write, and empower one another. When women, children, and men are empowered, our families are then able to design the world we all deserve. As a published author, Aquila is grateful to be able to share her story and experiences to motivational speaking and community activism in the following organization: TEA Academy. She's also staff at Healthy Black Families, NAACP, the Black Organizing Project, the Mothers to Mothers. She is thankful for her diverse work experience that have led her to her personal path. Yay. Okay, bear with me because it's my first time navigating through all right, it's my first time navigating through a webinar. So I would like to ask a question, and this is how I'm structuring this talk, right? I would like to ask a question of a Black woman in these days, say 8 months pregnant, right? And I'd like to group you guys as the RNs and midwives that work in the hospitals, and then the midwives and doulas that are working both in and out, right? So let me ask, so I'm 8 months pregnant and I come in, so prenatal. Lisa Davis, can you talk me through what prenatal is looking like now for mamas that are, for pregnant women that are sheltering in place?
In the hospital setting, you mean?
In the hospital setting.
Okay. The prenatal appointments are mostly telemedicine from what I'm hearing. Calling online or else, and only being seen in the office if there's something that they need to do physically.
I can speak to that
Yeah,
at Highland, Mike. Yeah. So again, I'm Jaisha Wren, practice at Alameda Health System, Highland Hospital. I provide outpatient clinic care, prenatal and postpartum at the East Oakland Clinic in Newark. And so what we're doing at this point, our clinics are still very much open, want everybody to know that, but we have reduced the visit schedule for people who are healthy and well enough that don't need to be seen so frequently as we routinely do when it's not pandemic time. So that's been a change since COVID-19. We've reduced the frequency of visits, especially in early pregnancy, and scheduling some visits as phone visits, so that people are not having to come into the clinic as often in an effort to minimize people's risk of exposure to COVID-19. But there are folks who have, certain risk factors that do make it necessary to see them in person each time, make that the safest thing to do. And for those people, we are still doing the same frequency of visits. So basically the message is, we want to see everybody. We want everybody to have the safe care that they need. And for some people, that means continuing to come in person. But the clinics are much less crowded now that we've reduced the visit schedule for other folks. So overall, it's a safer environment, easier to do that social distancing that's recommended during this time.
Are you seeing that a lot of the mamas are, soon-to-be mamas are anxious about not being seen on that, especially when you're getting closer to the birth on that weekly basis, versus relief that I'm glad, I kind of sense that you're checking me out, but I'm glad to be away from the hospital setting now?
I'm hearing from the people I take care of more worried about coming to the clinic than not being seen. Yeah, and I'm sure there's both. It's a mixed bag. But what people have been expressing to me mostly, I've gotten calls actually from people I see who are my clients that I've seen through the whole pregnancy, telling the clinic I'm not actually going to come to a visit until I talk to Jaisha and make sure that she really thinks I should come in, because people are really afraid of the clinic, of leaving their house, and so I have had to make calls to people just to reassure them, like, yes, I hear you. and yes, we'll reduce your visits, but there are certain times we do still want to hear you, because I can't check, heart tones over the phone, for example. We can't check your blood pressure over the phone. There's just some things we can't do over the phone. So we still want to see people physically when that's needed.
Jennifer, Phillips, Tora, feel free to chime in. Are you guys experiencing the same in terms of women's take of these new policies during pre-birth?
Well, I only see patients when they come into the hospital. So one thing that I have noticed though is that there's less patients coming into triage. When people come to triage to be checked out for preterm labor or other physical complaints, they're coming in for a real reason.
Mm-hmm.
Before all this happened, people would come in for a toothache or a headache that's not related to the pregnancy, or whatever thing bothered them at 3 o'clock in the morning. Now I'm seeing way less patients coming in triage. So that's been kind of a new thing that we're seeing with triage patients. We're seeing far less patients in triage. When they come in for a real reason, like they're gonna have a baby.
Jennifer?
Yeah, I'm seeing the same thing. I'm at Kaiser Oakland, and I'm seeing the same thing where mothers are coming in when they're ready. And yeah, and our triage has been less busy as well.
Great thing.
There's more of an anxiety around what's going on, what the environment is going to be.
Are you guys, I'm just curious, and maybe Jaisha, you speak more to this, but are you
Can I say something about that, Deb?
Yeah, sure.
So on the opposite end of what I'm hearing on the street, because I've been talking to some people that are pregnant and have been being advised by their providers to wait for the contractions, because normally it's 4 minutes apart, lasting a minute for at least an hour, and I'm not sure which providers are doing this, but I from someone who has talked to me, providers are like, wait till the contractions are 2 minutes apart. Or I had someone tell me that an EMT, she had called the EMT for some reason that she really didn't need to go in for, but he advised her to wait for the contractions to get really close together or have your baby at home. So they're hearing things from people also that is causing them to not want to come in. And my concern with that is that they might wait too long or have a symptom that they are procrastinating on that's serious.
Yeah, and we'll talk about the actual birthing. I want to walk through this, like, I'm 8 months pregnant. What is my pre-checkups and gearing up towards birthing looking like? And if I'm still in shelter in, here we are giving birth, what that looks like. So I'd like to switch now to the midwives. And the doulas. What are the experience? What has it shifted for you guys? Has COVID-19 shifted the experience of the checkups and the anxiety that women might be having of birthing? How are you feeling in terms of what does testing look like for you guys? Walking into a situation where, someone might actually be infected, but is perhaps not showing the symptoms, but is about to go in active labor. I'm just curious. Samsara, you want to take that?
Sure. I mean, it's changed everything. Very quickly, I was separated from my clients, and I work very close with my clients emotionally and physically as a doula. So that was immediately affected. And there was tremendous anxiety because my clients at that point, all part of their birth vision was having me and my assistant at their side. And so there was immediate grief process that we had to get into as soon as possible. And that is really not a time in your pregnancy where you're open to a whole bunch of changes going on. You've got it settled, you got your nest is made and your nursery is set up and you got your disposable, compostable diapers all purchased, your doula is set, you know, and then you have to deal with this big change. It was very hard for them. It was very hard for me in the style that I practice with people to make the changes to be able to get to speed and to even develop within myself in my practice how I wanted to practice and to assess my own fear level. I am 60 years old, so I'm in the high risk category.
Right.
And I'm just recovering. Last year I was sick half the year. So definitely have an impaired but improving immune system. So I had to check in with myself on how I was going to let that affect me. And I made my decision around that pretty quickly, as everybody has the right to do for their own individual self. And how we are working in my practice is that we are doing our prenatals over Zoom and childbirth ed over Zoom. We will go with our clients to their home in early labor and be with them in early labor and stay with them right up to that last minute, providing people who understand about what might be a problematic thing. We might want to move to the hospital more quickly. I myself am a very experienced doula. I've been doing this for 4 years. So I feel very comfortable knowing when things are in a good place or things are in a place where let's not be stupid. Let's get to the hospital, you know? I feel very at peace with that within myself. My younger doulas have the discretion to move more quickly than maybe I would because my experience level is the way it is. But we're home with families in early labor and we will stay with them until they're having contractions about every 3 minutes apart and then go with them to the hospital. We do that for 2 reasons. One is that we don't want to just, this is a big emotional connect that we have with our clients. We don't just want to drop.
Right.
Right. So I, am fine with going up to the hospital door and even up to the guard's desk, even if I have to. And I want the hospital to turn me away because we want to document that. The hospital turned me away. I was fulfilling my obligations to my client. The hospital told me no. That's important.
And Samsara, you've witnessed that. You've experienced that with hospitals during COVID-19. Yeah. Can you say which hospitals?
Excuse me. UCSF.
Okay.
Out of base.
Okay.
So far.
Okay. Can the other midwives chime in? What does birthing with you guys as the folks that help them journey through it look like? Asatu?
Well, the clients that I'm taking are due later this year, so I haven't had any births. I actually had a doula client recently who got the same message from Kaiser San Leandro and had to choose out of her sister, her doula, and her partner, which was very devastating. And we made plans to labor at home, but something shifted. So I wasn't included in that process. But right now I'm just following the recommendations of several of what other midwives are doing at home. Spacing out the visits, doing the essential visits. So I plan to do my 16-week visit in person, 28 weeks, just essential visits.
Right.
And it's really about empowering the mothers. I mean, I think that's our model of care anyway, to empower mothers. So a lot of midwives that I've spoken to are teaching their mothers how to feel the position of their babies,
nice.
How to just stay really connected with their babies. A mother can do her weight. A mother can be empowered to know how to measure properly. And, they do have some Dopplers. Most mothers already have them. You go to their houses, they have these little Dopplers anyway. So you can help her in knowing what our normal fetal heart rates are. A BP cuff. And I'm not saying that the mother do all her care, but that is our model to inform and to provide education and to empower. And then to be there for those essential visits, and of course the birth. And that's my plan so far, and to keep safe, to
be protected, wear all the protective to the best that I can, and to encourage moms. And so far, I've been telling moms to treat themselves like they would treat their newborn. And most of us observe the same way you treat your newborn baby and how you're protective of your body and your environment. It's the same way we deal with anti-corona. Postpartumly, pregnant, when you're pregnant, just being very careful. And so I don't think our model changes. It's just we're being more careful, and I'm going to observe the recommendations that NACPM and all the other organizations, the Alliance of Black Midwives. I've just been listening to a lot of webinars and just filling myself with information so I can inform women when they call and ask.
I think one of the things that's really precious and helpful about midwives, and I dare to say doulas, at least the doulas that I've trained,
Yeah, absolutely.
is that we already have those good hygiene practices in place. So we already, I don't walk into a client's house without washing my hands. I don't do that, and so it's just a matter of doing what we have been doing, which if we go back historically, we go back to our African midwife ancestors and our 20th century African American midwives. They always would wash their hands when they entered a family's home. That was of paramount spiritual importance, shifting the energy, releasing old energy to bringing into a family's home. So here.
I think you're muted, Debbie.
You're muted.
Thank you. Okay, so let's move to active labor, or just labor in general, right? So Tora, you talked a little bit about how you're seeing that when they come, they're pretty much ready to go. And I mean, I guess, Jaisha, is that your experience also? Like when they come in, do they seem to be ready to go? What's your experience?
Yeah, definitely. We are having less people coming into triage for checks and early labor, for sure. I think things like this, because people, same reason they're hesitant to come into the clinic, very hesitant to come into the hospital setting, unless the, contractions are feeling really strong and frequent. So we are seeing that. And in terms of how it's, our practices have changed in labor, we are wearing personal protective equipment more extensively than we did before, just for everybody, every patient, even if they are not having any symptoms of COVID-19 or have had a positive test, we're wearing an extra heightened layer of personal protective equipment. And then of course, if somebody does have symptoms or is test positive, then that's a really high level of personal protective gear and dedicated staff that would be caring for that person. And also the person themselves would be given personal protective equipment to wear, mask and such, and their support person. At Highland Hospital, we have a one support person policy right now, meaning that every person coming in to have a baby can have one person with them. That person can be any person of their choosing. It could be their partner, a family member, or a doula. It just has to be one person. That person is allowed to stay with them for their whole entire stay through labor, birth, and postpartum. And it just has to be the same person postpartum, so they can't be like switching out different people. I know that's been questions people have had, and those policies vary by institution. So other people on this call at other institutions, have other policies, but that's what we're doing at Highland.
Really quick, Debbie, sorry not to interrupt.
Sure.
And just thinking about that situation, can you also explain what changes have been made as far as what you can bring into that environment, as far as a tool for birth, blankets, are blankets from home allowed in? Are they still allowed to take robes, just so that people, you know, watching this are able to kind of prepare in that way as well? Environmentally, what has changed from your institution? I know it's going to be changed, but just speaking from Highland.
I haven't heard any restrictions on our policy of what people are bringing in. I haven't heard that as a topic of conversation at all. So I don't think there's any changes with that.
And I haven't.
Jaisha,
Mm-hmm.
Jaisha, and anyone else practicing in the hospital, can you all talk about when that one support person comes in, whether or not they're quarantined to the room or can come in and out, and bringing food in and out, those kinds of details?
Yeah, that I have not seen any kind of quarantining to the room.
So that's Highland. Tora, if you can speak to Alta Bates.
There are patients still walking in the hallways.
Oh, wow.
And
Okay.
as far as food, they can have food delivered, and they have to go downstairs to the first floor to pick it up. Or they can use the cafeteria. But I work the night shift, so I don't know.
Right.
It's not open at night. Yeah.
I'm at Kaiser Oakland,
Mhm.
and there's no restrictions in regards to that they're quarantined to the room. However, we do not have patients walking around in the hallways right now. The support person can leave the room if they have to go get something to eat. Our cafeterias are closed earlier now, which I think they're closed at 3. So I usually try to remind, if I work day shift, I remind them to make sure that they have enough to eat throughout the after 3 p.m.
Can you guys speak to the limitations put on the support person? I should give a little background. I had hoped that I would get written communications from these hospitals saying, these are COVID-19 policies. And I came to find out very quickly that it's a very rapidly changing situation, and they haven't even thought about putting together a pamphlet. And they were like, what do you mean? So I personally think it would be great if, and I understand it's, you know, depending on how many COVID-19 positive people are in the hospital, the policy will change, right? The more the virus load, the higher the protective protocols. But I feel like it's possible to have a handout that basically has, I don't know, for lack of better words, a yellow, an orange, a red, and how it switches according to the virus load. And at least if a mom who's thinking about birthing in these places can see this and read it, she can say, oh, okay, so it could be any one of these when I walk into the hospital, but at least she would have read it and known and been ready to suss out, okay. And the nurses don't have to spend time trying to explain to them why or how things are different, right? It could just be like, we're on orange right now. You know what that looks like. And even if while they're birthing, they don't quite realize it, it'll ring a bell because they read it, right? Before they walked in, before they're in labor. So Anna, I think Anna is of Alameda County. Hopefully she'll help me work with that to get something like that out of these hospitals around. But my question is, what are the limitations on the supporters? So when I called, I heard from some of the hospitals that they cannot leave at all within 24-hour periods. Some of them are like they can only leave twice or once within a 24-hour period, but they can't get switched out. Once you pick a support person, it will be that support person. So can you guys speak a little bit to that?
Well, we can only speak on that because it changes, like you say, daily.
Oh, wow.
I work on the weekends, so I worked last weekend, and we're not even getting reports in the nursing lounge anymore. Excuse me. So we have to pick our patients on the board, and then we get reports from the outgoing nurse. So that has changed from one week to the next week. So I don't understand. I don't see how we can even give the public information when we as nurses don't even know.
Do you think that's related to, do you have any notion of what that's related to?
Policy changes. as more and more people become positive or less positive.
I see.
They're treating more patients as possibly COVID-19 if they have any kind of fever, even if it's related to chorioamnionitis, so infection in labor, pyelo, any fever at all.
Uh-huh.
Yeah. So.
Jen?
Yeah, so yeah, things keep changing. I mean, I work maybe twice a week, and each time I go into work, it's something new. You know, one day we're no longer, like the nurses are no longer taking report in a common area. We're listening to a recording, so there's distance between us. It just keeps changing. There's nothing written there's nothing written. Each day is something new. So every time I go to work, I have to ask and find out, what are we doing today? What's going on?
Okay.
So it's up in the air for me as well.
And,
Yeah,
some of the things they just haven't thought through. And then as they start thinking them through, they make changes. Like someone asked me, does the nitrous, does it get aerosolized and is it safe? And I was like, oh my God, I never thought of that. I have no idea.
Yeah, we've stopped using nitrous.
We have stopped using nitrous as well.
Can you tell the public what nitrous is?
So that's used as a comfort, used for management during labor. It's nitrous oxide and oxygen put to the face, and that helps moms cope during contractions. We're not using any nitrous. We're not using also any oxygen unless necessary. We have to get a order. So given additional oxygen is part of our interventions, and that's not being used as well because of the concern of contamination. So we're not using that. So yes, I've had mothers who have had some anxiety over that because that was part of their birth plan, and we're not using it anymore.
If I can speak to that really quickly, that's really problematic, because what that says is that all the low-level interventions are not available to birthing people. Doulas, nitrous, hands-on support, that's all gone. So what's left? The narcotics and the epidural. What's left?
Exactly. And so for me, because because doulas are not able to come to the bedside, my role has become more involved with my patient, which is a good thing.
Good, yeah. But
you know, it's kind of sad. I actually miss you and miss having doulas at the bedside.
You do.
Yes, I do. I do, because you teach me so much, and these mothers, they really need the support. And yes, I noticed that the anxiety over the low-level interventions are that mothers have a lot of anxiety over that.
And can you just really quick, Jennifer, just repeat why it's not being used, just for the attendees?
It had when I asked, it had something to do with the transmission, possible something to do with the virus getting into the system, the oxygen system. I'm not really sure exactly why, but it has to do with reducing the transmission of infection.
Okay, so more of a precaution.
It aerosolizes. The nitrous aerosolizes.
Okay.
And so could spread as someone's asymptomatic.
Gotcha.
Okay, so clearly everyone, birth workers, laborers, are stressed out about being infected by this virus, right? There's very little research. I mean, there's some things we know about how it's transmitted, a lot of things we don't. Things shift around. So trying to make labor as easy for the moms as possible, but also maintaining a safety level. I'd like to talk about what some of the trade-offs have been in that process, right? And I'd like everyone to chime in on that. Clearly the role of a whole family, in my country, we tend to have 10 people come when you're birthing. Even in the hospital, we just take over. And people shift going back and forth, with the birthing mom. And having one supporter and having to pick between your partner or your doula or that's a very intense thing to have to do. But as such, what are some of the trade-offs, and how is it possible? And I'd like those of you working in the hospitals to really talk about how is it that a woman can set best practices before she goes into labor, right? So that she could have an easy, mellow, as natural as labor as she could possibly have. Who wants to chime in first?
Go ahead.
Okay.
For me, I think it's even more important to have a doula now than even it was before COVID, because your doula.
Lisa,
Yes?
Can you please repeat that again?
It is even more important to have a doula now than it was pre-COVID, because because studies show that doulas decrease unwanted outcomes, and they do. They care for you. They have a relationship with. They give you pointers that people in the hospital don't have time to or don't know about. They take care. A lot of in this Western medicalized institutions, they leave out the spiritual and the emotional, which is so important for successful delivery and postpartum. It's so underrated, and the doula really attends to that. The physical, the spiritual, the emotional, they are so important to your whole process from beginning to end and postpartum. And so, you have a takeaway in that you're not physically present at the laboring process, and you can FaceTime, thank God for technology. But the most important part is before you get to that labor room.
Right.
That will help you have a successful delivery.
Right. Aquila, can you chime in on technical difficulties in hospitals?
Just if depending on what hospital you're at and where your labor and delivery ward is and where your room is stationed, can determine if you're going to be able to, how your calls are going to go. So if you and your doula had worked out, your partner is going to stay with you during labor, and I'll call in if I need support, know that won't always work. And so what do you do in that situation now that it's just you and your partner and you don't have the support virtually from your doula? What tools have you already worked out? So just having that planned already, and understanding that you kind of have to go with the flow of things. The best way to go through labor is to relax. So just understanding that there are going to be changes that are unforeseen, and technical support is one of those. So yes, we are supporting you virtually, but yeah.
I thought it was very important to bring that part in, because I can see how if I was working with a doula and feeling very tied and knowing that really this quote unquote safety of my birth sort of relied on my communication with her. And I was like, okay, she might not be next to me, but I'll take this iPad. And all of a sudden there's zero communication because of, technical difficulties. So that's a good thing to think through.
Another very important point, though, is that no good doula will have her client be reliant upon her as the person who's going to get her through her birth. She's going to get herself, the birthing person is going to get themselves through the birth no matter what. Pre-COVID, that was the case. It definitely there's a beautiful emotional bond and a reliance physically, mentally, spiritually on the doula. but the woman's going to have that baby. The birthing person's going to have that baby. I'm not. I already had my babies. Did it.
I love that. So I'm sorry. Can you repeat that? No good doula.
No good doula would allow her client to be
Lovely.
dependent upon her. And it's not up to. It's not. The birthing person is going to have her baby.
Yep.
I'm going to help. I'm going to do my best to help. All that being said, I do believe that me, the doula, am much more effective to my client being in the room with that client. And that my absence has an effect. I can do all I can to try to mitigate that. Train up papa, train up auntie, train up grandma, whatever family member is going to be there, train up best girlfriend. If it's a single mama, it's a slam dunk that I get to be in there, so that's kind of cool. But, make sure, because ordinarily I would want not to have my papa or partner have to worry about being a doula. The papa or partner gets to be papa or partner. They're having a baby.
Right.
And most of my clients are first timers. So this is a person having their first baby. They have the right to be there with their mouth hanging open in mad admiration for their partner or wife. That's their role, and I'm happy to see them fulfill that. But right now, they have to step more into the birth coach role, and I get to help them do that.
Right. Right. Anybody else? Kiki, Jaisha, Sumi?
I wanted to just, I wanted to say that a really big trade-off that I think we can all be more willing to be courageous about is home birth. It really is. It's now more than ever, it is a safe place to have your baby. The viral load in your home is far less than the hospital. The risk of infection in your home is far less than the hospital. The opportunity to have your loved ones perhaps not right in your birth room, but close by is a little bit more likely in a home birth. Home birth midwives have modified how we practice. A lot of how we do it has already been mentioned here. We have reduced our prenatal visits. We're doing most of our visits on Zoom. We're wearing personal protective gear, but there's still a lot of one-on-one personal interaction, familial interaction and connection. And I think this is, I sometimes feel nervous during this COVID time or guilty during this COVID time because it is stressful. It is causing all of us quite a bit of stress. But for me, it's a really exciting time for us to challenge ourselves about about what we believe about birth and reminding ourselves that pregnancy and birth are normal. And that is confirmed over and over again by the fact that clinics and hospital staff are having to reduce their visits. That should be a reminder to us, not that we're getting less care, because I think hospital staff is still trying to provide quality care, but that your body knows how to give birth and carry a baby.
Bottom line.
I just want to echo what Asatu said, that in our visits, the cornerstone of midwifery care is encouraging our clients to be educated and be a part of their care. And this really amplifies that opportunity. Even though we're doing more visits on Zoom, there's more conversation, there's more describing how to take care of your own body, how to check for your baby's position, and encourage your partner to be a part of that process. So I just want to encourage our listeners to really consider that as a possibility, that if you are low risk and you've had a healthy pregnancy, you can consider having your baby in your home.
Right. Yeah.
Hey, Debbie, I would like to speak to, thank you, Kiki, for that segue. I looked through the questions and I saw some people are asking about how is home birth accessible in case the money to pay out of pocket is not readily available for whatever reasons, especially right now during this time. As home birth midwives and care providers, we are seeing a huge surge and uptick in inquiries. Does not mean that every single person will have a home birth. That's also something to have a paradigm shift around, because really the care that we give, the advocacy that we give, the way that we can fully inform our clients to therefore navigate what is the safest in every given moment of their care throughout pregnancy and throughout the labor and postpartum time. With that being said, I can vouch for every Black home birth midwife that I know, at least, that's serving the Bay Area right now, we all offer payment plan. We all offer sliding scale when appropriate for the family and when we have capacity to do so. So it's not that every single inquiry will receive that sliding scale. Maybe we're already at capacity for our own personal capacities financially to keep the sustainability of our practices for sliding scale opportunities. But we often refer to each other, and usually if I'm not able to, then someone else is able to take on that client. The biggest thing, like I said, is the payment plan. Something that I'm encouraging Black birthing people, who mostly are women, to do is to reframe where we put our resources, because we put a lot of resources in things that necessarily aren't, maybe should be prioritized right
Preach,
now.
Sumi, preach.
Yeah, cause I think that we have this idea. Kiki, I love Kiki. Kiki always talks about being 20 years old and paying for her home birth midwifery care and being like, I pay for that shit, you know? I think it's very powerful to think about that, because $5,000 is not a lot of money. We buy cars. We pay $10,000 these days in the Bay Area to move into a new home.
Mm-hmm.
You know, because you have the first and last month with a deposit. That's $10,000 easily. And people look at me like, $5,000. I'm like, sweetie, I'm telling you, over 6 months, $5,000. That's not that much. It's actually not. Especially Black families, we spend a lot of money on baby showers.
And I just want to chime in here, Sumi. I just want to chime in here and say, it's not just 6 months. It's the quality that is actually provided. It's so all around. It's so holistic. It's the kind of it's the kind of support that is actually needed for labor. And I also feel like it's what our communities used to provide that hardly exists. We've been so separated from our bodies, and they spend mega bucks, right, making sure that we are completely disempowered for a lot of reasons. And when you talk about Black women specifically, right, that goes straight up chattel slavery, right? So it's important for us to, I'm with you guys. I'm with you. Anybody else want to chime in?
Thank you, Debbie. I just really wanted to bring the point home, was saying that Black women have created a multi-trillion-dollar economic industry for beauty products. So I don't subscribe to the idea that we don't have the funds to support our Black midwives in our community. I don't believe that. I don't look at it like, oh, we need to subsidize for the Black women we can't afford. We need to educate our community on where to put our resources. That's all I was going to say around accessibility and midwifery care. So reach out to any of us, and we will have a conversation for your particular situation, a particular family member that you're thinking about, to make sure it's accessible. But we have to let go of the poverty mindset.
I want to hop on this because we have 107 people participating in this. So I want to jump in here and say, in these times, how possible is it for people to say, I'm going to open a GoFundMe because I really do not want to go into that hospital? And how many family members would be able to put down X amounts, right? So there's lots of different ways, and at least a lot of Black midwives, a lot of midwives in general, but a lot of Black midwives tend to work with people when they come to them. So anybody else want to chime in on this?
There's so much about this that I'd like to chime in about. It is a powerful time for us as a people to release our internalized suppression in this crazy ass country, excuse my language. You know, we spend all that money on beauty products, sometimes because of an underlying fear that we're not beautiful. And so we're running around trying to do all this stuff to bring ourselves up to a certain standard, and buying hair from India and doing all this stuff. We can have a whole nother talk about that. And then also don't want to shame people about wanting to look how they want to look. They do. But there is an important spiritual piece about, we put our money where our value is.
Right.
And so we need to take a look at, how do we really value ourselves? How have we as Black females been acculturated to be products that on the assembly line for all kinds of different corporations to make monies off of our back? And why do we have a problem giving that money to a Black midwife or a doula? Why do we have a problem giving that money to our own people to help empower us? Those are questions that as we as Black women and Black people and Black consumers have to take a look at. You know, and there's a lot of healing that has to be done there.
Right.
Part of our restoring ourselves as people is to uplift our birthing people. They're our future forever, to make sure there's always colored people on the planet. There's more colored people on the planet than the other kind of people anyway.
I want to read a comment here, Samsara, and I think it's important. Layla Hall is saying, money can be a very complicated matter for some, and it isn't as simple as vanity or consumption for some. And we all on this panel understand that, right? And I preface this conversation by saying a lot of these birth workers will work with people, right? Sumi started by saying that. We're specifically talking to that sector, right? So I would like to segue, unless any other midwives want to chime in about
Yeah, I think I hear I'm reading the comments as well, and I want to be clear that we are not trying to sound shamey at all. We're just inviting our people, including ourselves,
right,
to really look at where we place our values and where we think about an exchange. Unfortunately, in this economy, money is a tool for exchange, and so we're just reminding folks that that this can be a shared economy, that we're offering not only a skill or not only experience, but a service to our community. And unfortunately, that has to be the tool for exchange.
Right.
That's all.
Right. Okay, so I would like to go back to the birthing mom, and I would like to shift now from, actually, I want to talk about birth plans. Jaisha, because I think it's key, right? Two key things that have come out in doing this webinar for me is the importance of a doula right now, and the importance of a birth plan. And what, yeah, so Jaisha, speak to that.
Yeah, absolutely. I agree with what everyone has had to say. And I think that now more than ever, doulas are so important for people's support in, better preparing ahead of time through the education and support they do to help mentor people through the process of discovering what their preferences are, what their desires are for their birth, for helping to remind all of us of our rights as birthing people. And that's something that in the medical establishment, people are not treated as if they have rights most of the time, honestly, in a huge way. And so there's a big need, and especially during a pandemic, especially as a Black person, there's a huge need that we understand our rights as people, as patients, as birthing people, know that we can say no to anything, that consent is required for everything, even emergency procedures, separations from baby, all these kinds of things that are really scary that we hear about in the news happening at hospitals, around the country. We got to be strong in our rights framework and our advocacy. And I think that doulas play a critical role in that lead up during somebody's pregnancy and leading up to preparation for birth and for writing a birth plan. And as a midwife, I also help people develop birth plans and talk with them through different options. And that's how I see my role as a midwife, is to, as best I can, give people the information about all of the different options that they have, pros, cons, risks, benefits, alternatives, that kind of thing, and asking them how they feel about these various options. And I think that...
Can I interrupt here for a brief minute to say, because something that stuck me in our prep for this that really struck me is you very clearly said, I use my prenatal time if prenatal visits, one of the prenatal visits, to walk a woman through a birth plan. That to me seemed very, it was amazing, because when I gave birth 20 years ago, I couldn't imagine that happening. So I'm curious about that. And then I want other women to chime in on the importance of and how to do birth plans.
Yeah, that's something I do over time, actually. The length of our visits, and this is a huge plug for getting care out of hospital in terms of prenatal care, our length of visits in the hospital setting are very short. They are supposed to be about 15 minutes. I often spend way more than that with people, and I apologize to my patients being on this call and know that I run late, but I think that my patients also understand I spend a lot of time with them. So on the one hand, you know, us in the hospital, midwives in the hospital structure, you know, we're trying to practice as best we can midwifery model of care, which is to have dialogue and information. But we're stuck in a medical model where it doesn't provide time for that or value that. And so I am working on a birth plan with somebody every visit. I keep a list in my chart, in their, you know, chart of all the different education topics and what their preferences are going to be on that. And in each given visit, you know, today we may be talking about GBS. Maybe right now we're talking about, you know, medications for newborn today, or talking about family planning today. And I, you know, have that dialogue and then put their preference down, so that I'm kind of trying to help them build a birth plan over time. And so with the reduced visit schedule, what that means is, you know, it's really important to have those phone visits in between if they're getting care in our system, so that we can continue to have that dialogue, so that they can be building their birth plan, getting that education. And of course, getting childbirth education virtually is great. You know, if they can access that, there's people providing that now. And I'm happy to have phone visits anytime somebody wants to talk through something. And a doula is another way that they can get that kind of support along that process.
And Tora, I heard you say, what should you do with a birth plan when you come in ready to labor?
One of my first questions for patients when they come in is, do you have a birth plan? And if so, I make sure that a copy is put into their file immediately. And I make sure that if they have extra copies, and I encourage women when they come in to make sure you bring multiple copies of your birth plan, and keep it to one page, because I can tell you that providers will scoff at you if you have a 2 or 3 or 4 page birth plan. So try to keep it to one page, and make sure everyone who walks into the room gets a copy.
Very important.
We have a question really quick just from Inside Go
Sure.
relating to that. How are birth plans still being honored right now due to COVID?
We try.
In the best way.
We try.
Okay.
Yeah, I always try to honor them as best I can, regardless of the other circumstances. Yeah.
I try to honor them as well. I sit with the patient, read the plan, and we go through it together.
I know that
I feel the need to point out that right here on this screen, we're talking about the cream of the crop of nurses and medical people. So I just want to actually lift them up for that. I mean, Tora is the nurse I'm gonna look for if I'm in Activate. I'm like, where's Tora? Oh my goodness, can you hold that baby until the weekend? You know? And so it's, you know, this is the cream of the crop, these beautiful faces, these women I have so much respect for. And there's unfortunately a lot of folks that are not singing the same song as them in the hospital. So I just want to put that out there, that there are nurses that are not respecting birth plans. There are nurses that are pushing medications, and that's a reality.
And that's what I was going to say. That has not been my understanding back when I was pregnant, and nor has it ever been since, that nurses they actually see it as something extra to go through, right? So there's like a negotiation thing that happens in the hospital of like, okay, so what do you want versus what I think should happen based on what I'm seeing. So it's difficult to, the women on this panel are phenomenal, and that's the reason they're on this panel. I just thank you for that, Samsara. So going back to the birthing mom, she's birthed, and actually, can we talk about the C-section, the 39-week C-section induction thing? People, Jaisha, you could set it up for us.
Yeah,
what
sure.
is being offered, and then I would like Lisa to chime in, Lisa Davis, Sumaya, Asatu.
So I'll say that when this pandemic hit, there was talk at various institutions among OB-gynecologists mainly, that maybe in anticipation of a peak of this and a coming peak of this pandemic of more and more cases, that maybe it would make sense to either induce people's labor at 39 weeks instead of waiting longer for natural labor to start, in the idea that by the time the person's normal labor started, maybe then there'd be more cases of COVID. We might be in a COVID surge, kind of a state of overwhelm. There's also an idea that maybe we should move up people who are planning C-sections, maybe the date should be moved up sooner on that. Our institution at Highland Hospital, we have not done any of that. We think that's a really problematic mindset. We know that unnecessary inductions of labor can increase the risk of complications. They also take more time. So you're looking at a longer stay for somebody in the hospital. So it really makes no logical sense when our goal should be to encourage physiological labor and birth, normal physiological birth, that somebody could be, into the hospital in active labor, have their baby and get home, with as least complication as soon as they can, instead of having a longer stay. Inductions of labor typically take on average 3 days. Sometimes it's more than that, and a higher risk of cesarean if we're doing an induction of labor at 39 weeks with somebody who maybe her body's really not ready. And so, obviously with a cesarean section, there's increased length of days in the hospital and increased risk possibly of being exposed. So we at Highland Hospital have not done any of that. There's been no early, inductions for COVID. There's been no increase in the C-section rate for COVID. We are practicing our same practice around induction and C-sections.
Good. Yeah, I wish we could say the same.
And this is Alta Bates.
That Alta Bates. We're doing less inductions than we did before the pandemic. But we still are doing some inductions. And I'd have to know what our numbers are, but on the nights that I've worked, we seem to have more cesarean sections. Maybe that's just the nights that I'm there. I can't verify that that's true for the whole week. But I don't think people, when they say they're being induced, especially an elective induction, there's no medical reason for induction. They need to become fully informed, and they need to know that this can take 2 or 3 or 4 days. And it increases their chance of having a cesarean just by being induced. And patients are not told this. They're not given truly informed consent about induction.
So I want to hop in here and say, I read that if someone is suffering from COVID-19, not just has it and is, has a few symptoms, but is actually suffering from it, there's a way that your organs are pushed up, and there's a way that breathing is very difficult for you, just as a pregnant mama, that compromises, right? So it's possible that if you're really on the edge of I can't really breathe, it might actually be necessary. I can see that. But what's really
that's a medical reason. That's still
right. That's a very medical reason, and this is what I want. This is the really important thing to flank out, right? Is how one might think, okay, there's a birth that naturally progresses. Only God, I'm a first-time laborer, right? Only God knows how that's going to look. And but if I get induced, and I think there's this notion that for first-time laborers, if I get induced, it's like a factory. Like I'll open up, I'll spit the baby out, I'll go home. And it's very interesting because you guys talk about how it takes days sometimes, and there's a likelihood that you can actually go into C-section because it was administered. So that's key. But also, I want to speak to fear and what kind of a powerful tool fear is. And even if it's not being used as a tool by hospitals to rack up C-sections, I'm just, the notion of mentioning something in a way that that can kind of point to you thinking something else will happen because of it. Do you hear what I'm saying? Like there's, I just want to be in and out, and therefore an induction will do it. Why would
well, that's the thing, and folks are so frightened, and birthing is a sphincter activity. You have to release and relax a sphincter to allow a baby out. You have to create oxytocin. You have to go into that place where you went, hopefully the place you went where you made that baby.
That's right.
Okay, to grab that energy and help you have that. Everyone's terrified. This is not, it's so hard to get there. That's one of the reasons why I'm offering meditation once a week to everybody on my Facebook page to come and let's meditate and let's relax our central nervous systems and our autonomic nervous systems, because everybody, even if you're not pregnant, we're all like this. Even if we don't, I catch myself with a clenched fist and then have to breathe it out.
Right.
Everybody's so scared, and the way this media handles the situation is just inflaming the fear in an attempt to control people without respecting that they're smart enough that if you really gave them the facts, that they would do what's required. You don't have to terrify them. You know, it's old school bad parenting, right? If you don't want your kid to listen, you're going to put the fear of God into them, right? That's what our government and the press is doing to us. And when you watch that stuff, you find yourself all clenched up, and then if you're pregnant, how are you going to release that oxytocin?
Right.
So you get to the point where, let's just get it over with. I'll just get induced. Or I'll just get a C-section. Let's just get it over with. Because you can't relax.
Yeah.
I just wanted to add that regardless of, like Samsara is saying, regardless of where you're planning to deliver, this is a time to become actively involved in your care. And there are tons and tons of resources to educate yourself about how normal pregnancy is, regardless of where you're planning to give birth, about the laboratory testing that's done during your pregnancy, about ultrasounds that are offered during your pregnancy, so that you come into those prenatal visits, even if they are a little bit shorter or spaced out, with all kinds of questions that your provider can help you work through. I think while we're chatting, I'm just going to put some of those resources in the chat box so that people can go to those websites and start educating yourself. This is a time to remove that thought that you're just going to turn your body and your pregnancy and your baby over to a healthcare professional. It's really time for you to be the primary decision maker in your care, no matter where you're planning to have your baby.
Excellent.
Thank you, Kiki.
Thank you, Kiki. That's so true.
And try to, and I would say try to surround yourself with people who say yes to that, you know, because that is really, it's so important that we make sure that, you know, people have providers that support your right to make your own decisions and, you know, support you gathering that information. And so that's a good test of, you know, to try to see, am I in a good situation in terms of where I plan to birth and who I plan to birth with, is when you start bringing these resources and asking these questions, you know, how are those questions met? And how does that make you feel?
Right. Speaking of resources, so there's two things on my plate right now before we transition onto a closing question I have for you guys. One is I'd like to walk through postpartum, right? Because we walked through prenatals and then the birth and now postpartum. In the hospital setting, there's usually women are given 2 days, right, to be for postpartum.
After a vaginal birth, the routine is 2 days, yes.
Okay. And Tori, I see you kind of sometimes not.
Yeah. Legally, it depends on what time you deliver. Either 24 to 48 hours after birth for a vaginal birth and 48 to 96 hours after birth.
Yeah.
Cesarean section.
And is there a shift? Is there, are you guys noticing women wanting to go home immediately?
Sooner, yes. 12
Yes.
hours.
Yes.
Is pretty much what people are asking for, 12 hours after delivery.
Yeah, Jen, you too in Oakland, Kaiser, Oakland?
Yes.
Yeah. And then, so a lot of postpartum is now being done telehealth, I presume? If you've had a normal, anyone speak to that?
Well, sadly, this is Jaisha again at hospital setting, Highland Hospital. You know, the medical system as a whole, sadly, really neglects postpartum time in general. So what we were starting with, our routine is one postpartum visit. If you had a normal delivery, People are routinely pre-COVID getting one postpartum visit between 3 and 5 weeks postpartum. They can schedule additional visits if there are, certain circumstances, and, hopefully they're accessing lactation support. That's, additional visits for lactation, that's separate. But in terms of, with me, with a midwife, or with a, whoever the provider was, it's just one time, which is clearly, as we all know, definitely not enough. But that's an in-person visit. So we can't really drop down any less than that, because we were already really at the minimum. So that hasn't, what has changed since COVID is now it's being pushed out a little farther, that, we could go maybe up to 8 weeks postpartum for that physical in-person visit. But I am still having phone visits with people earlier postpartum to check in, about how they're doing, how they're recovering, how they're coping, how's the breastfeeding going, and referring them for breastfeeding support if needed, those kinds of things, which is really needed.
I have a question. It's going back a little bit and going back into prenatals. What are the resources that are given to mothers who have elevated blood pressures, glucose? What is being done? How are those mothers being followed? Are they given the resources at home, like the blood pressure cuff? Or
I know at Highland Hospital, so if somebody has a higher risk, risk factor like that of having high blood pressure, that's somebody who, is not going to be fitting into the protocol for a reduced visit schedule. So many people are still getting the same amount of visits that we would have done pre-COVID. It's not going to change if there's something we need to watch more closely, like blood pressure, blood sugar that's not in good control yet, or something like that. I know that, there is talk about getting blood pressure cuffs for people to take home at our institution. That wasn't happening before pre-COVID. So that's another, a positive thing with COVID, that people are realizing more and more the importance of being able to, people needing to be able to have the resources at home to take care of themselves. So that's a positive thing that we are seeing now. Hopefully people will be given a blood pressure cuff, but still we're not going to reduce visit schedules for folks who have those kinds of other conditions in pregnancy.
It's the same for us. We would probably go see that person and take their blood pressure. We have recommended, so first of all, I haven't had anybody with any complications since COVID has happened, thank God. But if we did, we would probably see that person more frequently, either through the tele-midwifery process and probably more in-home visits, and they would have to get a blood pressure cuff. If they cannot afford a blood pressure cuff, you can always go to CVS or Walgreens and have your blood pressure taken in the back. So there's just more communication and a lot more resources offered.
Right. Can we talk about, so I always tell, whenever I speak about my parenting, it to this day stumps me. Breastfeeding was harder for me than the actual labor. So I'm just curious about how hard that is on women who not only are not able to stay in the hospital for, 2 days, but their auntie, their mama, their, the neighbor they grew up with down the street that had 12 kids are not able really to come over because of the sheltering in place, right? So there you are stuck trying to figure out, and I told you guys this yesterday during our meeting, how, I had La Leche League, I had people coming to my house, I had community health people coming, and mamas trying to teach me or it was nothing to be taught. It was just, I had an inverted nipple that was going to be extremely painful until it toughened up. But what really allowed me to push through all that was the community, right? The women who were like, you got this, sis, you're going to do it. And having that 1 hour of people pushing me in the direction and giving me that inner strength that I'm pretty sure would have been unable to pull up on my own. So I guess my question is, are there support that you know of in terms of lactation for moms that just gave birth? Aquila, I don't know if you have an answer to that, or Samsara. Of course, doulas, but.
Yeah, one of our sisters, Hannaford, actually provides Zoom support in her Midnight Milk Club. So I just put the link in Facebook, and I'm also seeing a lot more virtual spaces popping up in forms of groups that are mimicking how we normally would commune together to support one another. So really utilizing our online platforms for these spaces in this time, I think, is vitally necessary. So we'll be putting up more resources on Healthy Black Families website, also our Facebook page, and then it's once again just how we're sharing information like this with each other.
Yeah.
So there's a lot. We're still doing the work out here.
I was just gonna echo what Aquila said. She mentioned Tonifer, but there are other lactation. They're a part of the birth. The whole, you don't until you have your breastfeeding right. You can't even relax as a mother many times. And so that lactation consultant is a very important part of the process. So if your midwife can't come to your home, we know that some of the lactation consultants are doing tele visits as well. And I believe that some will come to the house wearing their protection and still, because it's very, very important. And so I know doulas who are lactation consultants. Many midwives specialize in breastfeeding support as well. But I think part of this, part of our birth team, all of us here included, is our lactation consultants.
Yeah.
Yeah.
So I'm wanting to transition, Lisa Davis and whoever else wants to chime in on this, but I'm wanting to transition to, there's a lot, we've shifted now, a lot of comments about resources and what it looks like to just funding a midwife in order to have this labor, right? So Lisa, what do you know about this, that especially as midwives, that can get some leverage in terms of
So as a home birth midwife, we can accept insurance. I can accept insurance as an out-of-network provider, and some of our home birth midwives are Medi-Cal providers, and they can
you repeat that?
I can accept insurance as an out-of-network provider, and some of our like Kiki, she is a Medi-Cal provider, and some of our other home birth midwives are Medi-Cal providers. The problem is a lot of people have HMOs that don't have privilege to, they don't have the privilege to the benefit of having an out-of-network provider or a PPO, and so they won't get approved for insurance. So that's one of the hangups, is that like a place like Kaiser they don't accept it. We can't accept Kaiser insurance, and then if you have Blue Cross as an HMO, then we can't accept it. Well, I can't accept it. There are some midwives who are in-network providers, but I'm not one of them.
Can I just clarify that I am a Medi-Cal provider, but getting home birth covered by Medi-Cal has proven to be very, very challenging. So currently, I just haven't been successful with that yet. I put in the chat that we need your support, like Medi-Cal and the Department of Health needs to hear from birthing folks about that issue. But it's a goal. It's definitely a goal to try to figure out how home birth can be covered by Medi-Cal.
But from the whole community, yeah, they need to hear from the whole community, right? Like, this is what we need right now, because I think this virus presents a very an opening. And
I would love to talk, about that more, Kiki, because as I'm learning more and more about insurance, it's so archaic and patriarchal and unfair that we give this really pristine care, but our care is valued so much less than in a hospital setting, and our outcomes are just as good or better. And even when you research among Black midwives, our outcomes are outstanding. But our value and our worth is so diminished in this industry. They don't know what we do. They don't know what kind of care we give. They don't understand. There's a lack of knowledge. And so I would love in another realm to talk about how we can maybe organize against that.
We need to remember too that doctors sit on the boards of insurance companies.
Yep.
You know, I mean,
I'm sorry, can you repeat that? Samsara?
Doctors sit on the boards of insurance companies. Okay. And the stated opinion of doctors in the medical profession in this country is that home birth is child abuse. That's their stated written opinion.
Yeah.
Wow.
And usually that's coming from someone who's never
Never seen a home birth.
They've never been in a home birth situation. They don't know the kind of care we give.
Exactly.
They're speaking so from ignorance. So I really want to change that.
Let's do it.
I wanted to speak to a comment that was in the chat. I think is really, really important that we don't bypass, we don't overlook. It's something that we really hear a lot, especially as Black providers, is that right now on social media, even on the news outlets, everyone spills out the statistics. Black women are dying 3 to 4 times more likely than white women, despite whatever you do. Beyonce, Serena, don't matter how much money you have, anything, the statistic does not escape you. Someone who I believe, I'm assuming is pregnant, is wondering, like, since that is a fact, what can I do to keep myself safe? It was way up in the chat. I saw it like a while ago. I was waiting for a time to intervene to project this. And it's something that we get all the time. People are always in my inbox devastated, like, I am pregnant and I am terrified.
Exactly.
I would say it's even a dystocia. Dystocia is something that we describe in medical terms as something that obstructs labor, that stops the flow of labor from advancing. And I have had many, many, many Black clients who in labor at times, in prenatals for sure, in labor at times, and postpartum bring up these really horrifying feelings, emotions that are valid and real. Something that I remind my clients as a Black person is that we do not live in a vacuum. The same way that it's dangerous to give birth being Black in the US, it's dangerous being Black in the US. It doesn't change because you're pregnant. It doesn't change because you're giving birth. It doesn't change because you have a newborn. It's the same life you were living, the same reality you're walking in. The same reasons why it's dangerous are the same reason why it's dangerous, which is why it doesn't matter if you're Beyonce, because you're Black.
Right. I would like to quote in one of these webinars that Black Mama Matters put together, Jamara Amani, who everyone on this webinar should go and look at these webinars when they're up, which I think will be next week. They were phenomenal. But what she said was, and I wrote it down here, is the root causes of Black maternal mortality are white supremacy and privilege. Structural and institutional racism are pre-existing conditions. Let me repeat that. Structural and institutional racism are pre-existing conditions. The child welfare and healthcare systems still are operating on the 1964 Moynihan Report, which blamed Black women for our economic status. And that's the bottom line, right? That's the cauldron in which we're operating. So thank you for that, Sumi.
So I wanted to just affirm, like, what we're all saying just now around Black midwives have the best outcomes for Black people. Our outcomes are
bottom line.
Our outcomes are outstanding. I want to say it over and over again. Our outcomes are outstanding. If you are high risk, you can still hire a midwife. We can give you concurrent prenatal care in your home or in our offices, and we can be there in your labor, depending on your health condition, up until the point where it's safe and where you need to go to the hospital. We can accompany you in the hospital, advocate alongside with you, and we can give you postpartum care in your home. I think that we need to just really make this a really big priority in our lives. If you're pregnant, you need a midwife and you need a doula. That's just the bottom line.
Yeah.
That is so important what Sumi just said. So thank you so much, Sumi, for what you just said.
Yeah.
Because
and I want to just say that the word for
let me finish real quick. Just want to say that the environment that the Black birthing person is going into, the hospital looks at her body as already a time bomb about to explode. The issue is the Black body. And it's important to have a care provider who sees that Black body as beautiful and healthy and vibrant and addresses the pregnancy from that aspect. Go ahead, Ms. Lisa.
I just wanted to emphasize what Sumi was saying. The word for what she's talking about for having concurrent care with a midwife is called montrice. And so that if you know, because there are certain risk factors that keeps you from having a birth at home, but if you still want the care of a home birth midwife, we can be your montrice. And also, I wanted to emphasize the fact that that the hospital is historically one of the pillars of that structural racism that can be part of the problem as to why a lot of these outcomes are not what they should be. So yeah, I just wanted to emphasize that part.
Yeah, Sumi, thank you for that. Contextualizing this conversation and why it's important to have put this panel together is key, which I did not do. But it's key. It's what it is. And thank you for catching that comment, Sumi, because and I highly recommend you guys go to Black Mama Matters website and look at these, like not just using our bodies for giving birth so that a white master can make more money, but down to, which we all know, right, experimenting on our bodies. So, and the hospital institution is a direct birth.
Yeah.
Pun intended, direct birth from that, right? So, yeah, we need to big each other up. I just, I'm so honored. I'm just so honored. All of you are phenomenal women. So
real quick,
sure.
This is Jaisha. I just want to thank you all for catching that comment and spending some time on this. And I want every, person who's on this call, particularly pregnant people, just to know that, yes, that risk is there. Yes, we live in a racist white supremacist context that creates these conditions that impact us in this way, but it doesn't have to be this way. And There's nothing wrong with our genetics. There's nothing wrong with our biology. And we actually do have ways that can improve our outcomes, like everybody's been talking about. We know that Black midwifery improves our outcomes. And we also know that methods like centering pregnancy, group perinatal care, are evidence-based models to reduce our risk for complications like preterm birth, low birth weight, meaning babies born too soon or babies born too small. We have evidence from great midwives like Jenny Joseph in Florida with her JJ Way that demonstrates the power of Black midwifery to provide holistic wraparound, creating a village of support for people. And that's what people need. And that's what we have to do right now in the state of COVID, is figure out a way for people to still have that supportive village of Black birth workers. And we know that that can reduce those risks. So I just want everybody to be comforted to know that, our fate is not predestined. That
it's not. Thank you. So we're coming close to our end. So I would like to ask a question. First, I really want to thank you guys for your incredible perspectives and the years of labor. You like that? That you put into it. And just the beautiful women that you guys are. Thank you for being assets in our community and continuing to be. So I guess for a question that I'd like you guys to cycle through is, being a first-time Black pregnant woman in the midst of this pandemic, ready to give birth, would be in a sheltering in place town, state, nation? Words of encouragement?
Well, one, tell people that we know they can birth their babies. They've grown their babies beautifully. They can have their babies. And one of the things that I do as a nurse working in a big facility, I have nurses tell me all the time that, well, when there's home birth transfers, those are train wrecks. I said, well, they're not always train wrecks. And we have really competent home birth midwives who want the best for their patients and their clients. So they bring them in when they face something that needs medical attention. So we don't see the home births that are successful and go well. We never hear about those. So I think that's one thing we might want to address, is how well home birth does work out for people and for families, because that information is really kept on the down low, and people don't know about that.
Say the word and we will come in and do a report on how well it goes. Let's build a bridge. Now is the time.
Yeah.
Yeah.
And I think that as well for unassisted births. That is happening right now. Women are deciding as well to have birth unassisted, meaning without a medical provider, whether that be a midwife. And so knowing that this is going on, to know that they are having successful births. Some births aren't going successful. So to reach out to midwives such as yourself that are able to help with things such as documentation, because you will run into some hiccups and some obstacles as far as when it comes to documenting your beautiful, successful home birth that you did with just you and your family. That is happening and has been. I always recommend going out for support, but once again, people have a right to choose the way that they are going to deliver.
Right.
So just keeping that in mind as well, knowing that if you're going to consider an unassisted home birth, please make sure that you do your research. Please make sure that you're aware of all risks, just as you are aware of the risks within the hospital setting, and that we send peace and love, to you. I think this is a time, so I just wanted to take that time to just include that unassisted home birth is a way of birthing as well.
It is an option. I'll go after Aquila just to echo. I think we're flowing in the same direction. That now is the time. Kiki already said it. Aquila said it. Sumi said it. All of our beautiful midwives and birth workers said it. It's the time for mommies and families to educate themselves. There's so many resources. YouTube University. I mean, there's so many websites and so many birth workers on Instagram. There's so much information. Now is the time to settle your mind, get the information so your mind and heart is settled and it can still some of this anxiety. Your mamas and your great-great-grandmothers were birthing babies, multiple babies at home.
Yeah.
We were birthing multiple babies at home with, and so we can do it again. But they believed in it. They believed in their bodies. And that's what we need to return to. We're returning to gardening. We're returning to the earth. So we need to return to our bodies and trust our bodies. Know that we can deliver these babies. And that our sisters can help us, support us. Like Samsara said, we have to train up our aunties, train up our cousins. You shouldn't be at your birth alone. You need your doula. You need your support system, however it looks. If you're at the hospital, you still need your support system. And so just have faith in yourself, have faith in your body, fill your mind, pour into yourself information that supports you and calms your spirit, because because this is where we're at now.
Right.
And moving forward, this is where we're going to be.
Yeah.
Yes. Thank you.
Can I share some final words? Thank
Yes,
you.
ma'am.
I feel like I don't feel like we've stressed the breastfeeding enough. I just realized that's so important. I want everybody to hear it so many times that, I have a lot of my people I'm taking care of coming in and worried about their babies and the state of this COVID pandemic, right? And so I just want to stress that breastfeeding your baby is the best thing you can do for baby's health anytime, all the time, but especially during a viral pandemic like this. That's your baby's protection. And so we want to support that as much as possible. And I just want to let folks know, I know not everybody knows a lot of the details of our midwifery practice at Highland Hospital, Alameda Health System. We're a team, a robust team of 20 midwives. We have 5 Black midwives. I just want everybody
Say that.
Okay, 5 Black midwives. So we roll deep. We are here for you. And our hospital policies really are, you know, we try hard to center our people in our care. We, like I said, we have one support person policy, but, you know, even though that's firm, people still have the ability to advocate for themselves, and we operate on a shared decision-making model. Okay, so there is no forced separation of mothers and babies, even if you do get COVID-19. That's another thing people are coming in and saying, and I don't think we said that enough on this call. I just want everybody to know, you know, of course, we want you to not get the infection, but if you even have some symptoms, you get a fever in labor, or you even have a positive COVID-19 test, you still retain your bodily autonomy for yourself, for your child. You make your own decisions about what happens to you. You make your own decisions about keeping your baby with you versus having baby maybe be in the NICU, maybe pumping your breast milk to give to baby. Those are all options, but you can also still have that skin to skin and put your baby directly to breastfeed.
That's right.
Chest feed, whatever you, you know, you want to do. And so our official policy at Highland Hospital is to support shared decision-making. Now, I can't promise all of the docs are going to be, you know, where people are going to be on the spectrum, but that's our official policy. And so, you know, I know that's not the case in a lot of other settings. So just want people to know that and feel safe in that, and know that we're here to advocate for you.
Right.
And advocate with you.
Anybody else want to take that question of words of encouragement to a Black mama birthing in these times?
I'd love to say the most important thing that I think that I can say is that I love you.
Oh,
I love you. Thank you for having a baby. Thank you for doing that. Thank you for doing that for me. Because a little bit of me is in you. We all carrying each other spiritually and by blood and bone. We are the people, we are the descendants of the people they could not kill.
That's right.
So, you know, thank you for doing that, and love and light to you. Definitely, as your sisters have said here, you can have your baby and you can be a fantastic, fantastic mama, parent, and your partner can be the most brilliant and wonderful papa partner. Okay, don't let any nonsense that anyone has told you, even people that you love, if they tell you nonsense, you get to, you know, respectfully decline to participate in that kind of thinking. Any kind of thinking that has you as less than marvelous and amazing. Just think about what it takes to get pregnant. It's quite amazing that any of us are even here. We're all walking miracles. And so thank you for bringing another miracle into our midst, your beautiful child. And I personally, and I know all these beautiful sisters want to do everything they can to help you do that as splendidly as possible.
Something that I was reminded of just recently is that, and that I want to take to heart, is that I want to sit in the wisdom of mother's intuition. It is very powerful. Know that you know your body, and sometimes it might differ from what the provider thinks or believes, and you have the power to follow what your body is telling you to do. So I just want you to be encouraged that you can do this. Your body was meant to do that, and everything, you have everything at your disposal to have a baby. I always say that this was intelligently designed. We don't need all this extra. So that's what I want to, that's how I want to encourage you.
thank you.
Yes, I would like to say, piggybacking off of Lisa, follow your intuition, follow your heart. you know what is best. You know what is best. And as a practitioner, healthcare practitioner, I'll do my best to honor your wishes. And that's what I'm here for.
Yeah, I want to give a real shout out to you, Jen, and those of you who work within the system to be that buffer. It's a very important piece for those who are lucky enough to birth while you guys are on duty.
Thank you.
Kiki sends kisses. Anyone else? Last words for the birthing mama who is feeling the way she's feeling?
Well, you know, my thing is I try to give my patients more love, because that's the key. You know, I always try to give them love anyway, but I think in this time, we just need to give them more.
Yes,
Yes.
absolutely. Jaisha. Hi.
Oh, you're cutie.
I'll say hi.
Oh,
We're loving up the mommies and the babies.
cutie. Oh my goodness, what a cutie.
Kiki's still on? Kiki's not on anymore, huh?
Hello. No, she's here.
Oh.
Kiki, she's here.
She helped.
Hi, Linda.
Yeah. Bob was born at home, and he was so lucky to get to have Kiki there. Huh.
Nice.
Kiki, she was there when you were born.
Aww.
He's like, whatever, I don't know.
Whatever.
And so I would like to say, if there's no other closings, that there is in the chat box, there's a survey about your experience. So next time we put this on, it could be that much better. A link to a survey. And we love you all.
Thank
And
you
with
all
that-
for being here.
Something I am wondering, Debbie, how people get our contact information? I'm guessing some people will want to reach out to us. What is the best way that will happen?
So we can give your phone numbers out to the email serve with them. There were 180 something people that registered for this. So if you all are good with that, and I'll be in communication with you guys to send the links to your websites, your phone numbers, whatever it is that you might be, yeah.
Okay, awesome.
And also everyone who wants more information, I should point out that Alameda, Jesus, I forgot this. Okay, so Alameda County Public Health put out a piece, and I couldn't share it, but they put out a COVID-19 sheet, which we will also email out. We'll attach and email out to everyone for information. Thank you, Anna, and Elka for working on that. Much love to the both of you. Yeah.
Thank you, Debbie, so much for coordinating everyone.
Yes.
Thank you, Debbie.
Thank you all. Thank you, Debbie. It's
Much
beautiful.
love, everyone.
Thank you, Debbie. Mwah. Thank you. Bye, sisters.
Bye, everybody.
Bye, everyone.
Bye, cutie.
Bye, cutie.
Little Batman.
Bye-bye.
I miss Sebastian from that age.
Yes.
Have a
We're
good
gonna sit here. There you go. Everybody's dropping off. I was like, we're gonna
Akila,
stay
can
here.
you
Yeah,
put up the link for the survey? People are asking for it.
absolutely.
It's in the chat box, you guys.
It's in the chat box twice.
But she's gonna put a link up right now too.
Yeah.
So just link
So I
on
just
it.
put it in last time, and then I'm going to put, should I share my screen? Yeah.
Let's make the
Quick
survey the last
question.
thing.
Would you
the
like
last
us to do
thing.
it too?
Sure,
Yeah,
please. Yeah.
Okay.
Yes.
Just checking. All right.
We're a nonprofit. The more information we get,
Mama Yana.
Okay.
Hey.
Hi, Mama.
Great
I'm out.
webinar, everyone.
Yay.
thank you.
Thank
Can you see
for,
it?
being part
Guys,
of it.
can you see it on my screen?
I see a black, but it says survey link.
Yeah,
That's it.
But we can't link to it.
Can't touch it?
You-
Okay.
Can you just copy the link and put it in the
Chat.
chat?
Right. Oh,
And yeah. Yes, love.
Thank you.
we can email it out to people as well, right?
That's what I have
So
planned on. Yeah, planned on
thank
doing it
you,
through
Sheila.
Eventbrite.
You're welcome.
But here it is again. You got it.
That's it.
And then I'll be in touch with anyone if I need more of the information. I'm going to compile the resource list right now. Get a green light from Rawa and then list everyone that was a panelist, all their contact information on the site as well.
So I'm trying to access the link now. Hold on.
What's doing?
Where'd it go? It's already gone. Everyone else quit commenting so we
Oh,
can get
I see it.
the link.
I just
Copy and
accessed
paste
it.
in your browser, and then it
How
should
did you
be
access
your
it, Debbie?
your
Oh,
Google
so
Drive.
copy and paste it in the browser?
Yes.
Well,
Okay.
I was able to click right on it.
You can click right on it. See, give or
I was
take,
able to.
depending on your computer.
That's what I just tried to do. Like, okay, thank you. One or the other.
Did it work?
Can't get to it. There's so many comments.
Yeah.
Here it is.
Okay, here, I'll send it just to you. Let me see.
Okay. I'm looking at the seeing if I can access it.
Okay.
It won't let me. Okay. I copied and pasted. I'll paste it in my browser now. See how that works.